just turned around and looked at me and said, "You demon, you hearing that kind of thing from your own father, how do you think you feel?" We used to have terminologies like abiku, that this one is being born to die. I had issues as well too with dating, you understand, because of obviously sickle cell anemia. The ladies I met as well too, they have to be AA. It's not whether because I love you, love conquers all. Love does not conquer all. Anyways, let me just put it that way. It does not. But the person I was really into that time when I was in medical school, she's a doctor as well too. She thought, because I told her, I am this, you understand? The only way we can work together is if you're AA. And she said she's AA. I was like, okay, no problem. So right from the beginning, I had already spelled it out. I was a medical student, so we knew the impact of what could happen. Unfortunately, one day she wanted to donate blood for I think an accident victim, and our boss or our teacher collected her sample and tested her blood and found that she was AS. That fractured the relationship. Somebody living with sickle cell does not have an adult hemoglobin A, the normal one. It's actually 0% usually. Imagine a sickle cell patient, for example, having a blood level of 24, 25%. That's like almost half of what another person have, and you are being subjected to the same stress. Who do you think is going to cope more? But studies that were done actually found that the prevalence of the condition in Nigeria ranges between 1 to 3%, of the population.
1 to 3% of Nigeria's population.
So
let's say we are approximately 300 million.
300 million. So imagine 10 million Nigerians living with sickle cell anemia. They coined the word actually sickle cell because the cells actually look sickle, like a sickle that you used to harvest grains. Normal cells are supposed to look round.
Okay, round.
So that's
So but this
one looks like a sickle, like a half, crescent of a moon.
Let's do some linking here.
Okay.
What is AA? What is AS? What is SS? What is BS? All of those things.
Okay. All right.
Thank you for watching The Yellow Mic. My name is Kongs Shamaki. I'd like to invite you to help us reach 1,000 subscribers. Also, like this video and share to your friends, and let me know what you think in the comment section. Dr. Segun Adeyemi, you're welcome.
Thank you very much for having me.
Yeah. As a pathologist,
yes,
what is sickle cell anemia?
Sickle cell anemia, it's a condition where an individual inherits 2 copies of the abnormal hemoglobin S gene, 1 copy from either parent, and then they come down with what we refer to as HBSS. So in medical terminologies, we say it's a homozygous inheritance of the abnormal hemoglobin S gene. That is sickle cell anemia.
So it can only be inherited?
It can only be inherited, yes. It's an inherited condition.
What's the origin of this condition?
There were postulates actually, and it was related to the endemicity of malaria in sub-Saharan Africa, or just African continent generally. But other continents also have their own form of sickle cell, particularly the Arabia Peninsula as well too, so they have their own. So they attributed it to malaria, that it's a form of an adaptive way of us combating malaria, such that when the parasite enters the red cells form that sickle, and then the body destroys it. So it's supposed to prevent the spread of malaria in the red cells. But unfortunately, probably maybe nature or the designer didn't look at the aspect that, okay, what if it's a double inheritance now? It will cause a more severe condition, which is sickle cell anemia. So in fact, people that have AS, so to speak, that is the A is the normal adult hemoglobin, and then the S, the abnormal one, tend not to have that kind of, breakdown frequently. That's just medically, speaking now. So it was actually identified or tied that, okay, probably because of the endemicity of malaria, in the African continent, that's why, the mutation, occurred to protect us from malaria infection. So that's what is actually being peddled as the basic cause, underlying pathology, so to speak, of the essence of sickle cell anemia.
So there's every possibility that this was engineered by a person?
Well, I will not say a person. Just like, of course, there has to be a creator. I don't believe that we all sprang out from Big Bang, so to speak. You understand? So it's more of, I will not call it a design flaw, because according to the creator, everything he created was good or is good. But now, seeing sickle cell anemia, I won't say it's good. You understand? So it's not probably maybe not a human design.
Okay.
Maybe not a human design, maybe evolution, but of course we know that definitely something happened somewhere.
Do you know at what point people started experiencing the sickle cell anemia?
Okay, it has been dated far back as the 18th century.
18th century.
Yes, as a matter of fact, there was a document, it was documented that a Ghanaian family, 17 something or something like that, that started experiencing the typical signs and symptoms of sickle cell. But the documented one was in the early 1901 or something like that. It was actually a medical student or a dental student, you understand, that they found that the guy was from Grenada, I think, or from the Caribbean, just having jaundice and all those kind of symptoms. And then the doctor, there was the Ernest Irons, and I've forgotten the other name of the other doctor now, that actually, just took a look at the individual, examined the blood, and then found the typical sickle-shaped red cells. And they coined the word actually sickle cell, because the cells actually look sickle, like a sickle that you used to harvest grains. Normal cells are supposed to look round.
Okay, round.
So that's, yes.
But this
one looks like a sickle, like a half, crescent of a moon, something like that. Yeah. So they coined the word sickle cell. So it was actually something like that was the one that is actually officially documented in the early 20th century.
So how does the shape of the cell affect someone's health?
Okay. Physiologically, the red cell, the way it's designed, so to speak, it's supposed to be able to squeeze through blood vessels. There are big blood vessels. Just picture highways and I mean roads in between cities and in between houses and stuff like that. You understand? So you have larger vehicles that can ply highways, but they cannot ply roads in between houses and stuff like that. You understand? But the way the normal red cell is designed is that it should be able to go everywhere in a part of the body, even the tiniest of blood vessels. We call it vasculature. It should be able to squeeze itself and go through, to deliver oxygen to the tissues. Okay, I've come here. Okay, take oxygen, take glucose, take this, take that. You understand? But the problem with sickle cell is that once it forms that sickle shape, it hardens, and then it loses its ability to, meander through the tiniest of vasculature. Then it blocks the blood vessels. So once the blood vessels is blocked, normal red cells, occasionally they have ones that have not sickled, you understand, will not be able to pass.
Yes.
And then it will form like an aggregate, occlusion, and then prevents blood from flowing to that organ. Usually when blood stops flowing to an organ, there's something we refer to as ischemia, because oxygen cannot get there. So they say then you have ischemia, then it dies, that's necrosis, and then the organ gets damaged. That's what we refer to as end organ damage. So that terminology, what I've just explained now, is what we call vaso-occlusive crisis. That's just the layman explanation of what happens in vaso-occlusive crisis. Exactly.
Yeah. So at what age do you think the crises are severe for sickle cell patients?
There's actually no age, apart from probably when they are at birth. There's another form of hemoglobin we refer to as fetal hemoglobin. Now, this fetal hemoglobin has the propensity to hold on to oxygen more. It doesn't give it off easily, like the sickled hemoglobin. So when a baby is born with sickle cell anemia, because of the high concentration of the fetal hemoglobin, the symptoms and signs, don't come early, So usually there are triggers: dehydration, lack of oxygen, acidity, infections, and things like that can trigger and cause the red cells to sickle. But because of that fetal hemoglobin, because it holds on to oxygen, it prevents the cell from sickling. You understand? And then newborn babies, maybe they live for a few months, usually will not experience it. But by the time that fetal hemoglobin, because actually it got to a point in time that the fetal hemoglobin will switch to an adult hemoglobin, which is the hemoglobin A. So at that time of the switching, that's when they now start experiencing the symptoms, because sickle cell patient, if somebody living with sickle cell does not have an adult hemoglobin A, the normal one, it's actually 0% usually, except if there's a form of that one is something more technical. Maybe we might get into it later.
Yeah.
They have no adult hemoglobin A. They will usually have more of the hemoglobin S. You understand? So by the time it switches and the adult hemoglobin A is not available to carry oxygen, that baby now starts having signs and symptoms of sickle cell anemia.
So the reason I asked that question is
Yes.
I've seen a pattern of 5-year-old children dying as a result of sickle cell. Is there any that was? And then I heard that at the age of 5, and I think somewhere around late teens, and then around 25, 28, like people, like I used to have a teacher who died at the age of, I think, 28 in secondary school. He couldn't survive that particular crisis period.
Yeah.
Is there any relationship between age and this crisis?
There's actually no relationship.
Okay.
Usually, once from the first time they start experiencing signs and symptoms, usually are from 4 months to 6 months.
Oh, okay.
They are at risk. Any crisis is actually a severe crisis. It's as dangerous as anything else.
Oh, okay.
Can take their life. So there's actually no age, let's say, limit, gap, or an age that you attain, then the crisis will now become severe, and then so every crisis is treated as something serious, because a full-blown crisis can actually take the life of the person living with sickle cell anemia. So you only know about 5 years. How about those days before we got knowledge about what this is? I remember we from the western part of the country, I think probably we were the worst hit. We used to have terminologies like abiku, that this one is being born to die. Because when they start seeing those symptoms, they know that eventually they will die.
So it's linked to sickle cell?
It's linked to sickle cell, yes. Even the name, Kashimawo, you remember MK Abiola? We believe that his family must have had that gene. Kashimawo means, okay, let's just keep waiting to see whether this one will survive or not. You understand?
Wow.
So we actually, the western part of the country was actually a worst hit, because you have babies, they have babies that probably will not live up to a year, 2 years, 5 years, they die, 10 years, they die. You understand? So they call them abikus. That's the Yoruba, this thing. Before you now found out that, okay, it's actually linked to sickle cell anemia. They will have brief illness, yellow eyes, swollen stomach, painful hands, and everything. And before you know it, because they can't treat appropriately, they didn't know what the problem is. They die, and then they say it's abiku, born to die. So that stigma still lives on, even till date. There's still, probably maybe peers, use it to label people living with sickle cell anemia, which I think is actually not something and lines to live with.
Let's do the math.
Okay.
What's this case like in Nigeria?
All right. Study that was done. I actually also worked on sickle cell anemia patients, in my dissertation as a specialist. But studies that were done actually found that the prevalence of the condition in Nigeria ranges between 1 to 3%, of the population.
1 to 3% of Nigeria's population.
Of Nigeria's population.
So let's say we are approximately 300 million.
300 million, for example.
Yes.
So if you let's use the upper limit of that prevalence. If you take 3% of 300 million, you should be left with something in the range of 9 million.
9 million.
So let's just round it up. Let's say 10 million. So imagine 10 million Nigerians living with sickle cell anemia. It's very significant.
Goodness.
Although people can look at it that it's just 1%, it's just 3%, it's significant, because we are also when I say we, I mean I also live with sickle cell anemia. We are also in the, spheres that matter in the country. We are doctors, we are lawyers, we are surgeons, we work with presidency, for example. We work everywhere so too, so we also matter. And I think government should actually recognize, people living with sickle cell and give them that, that credit for doing a little bit extra than every other person, just to be, or just to do what they're trying to do. You understand? So maybe our discussion might sway us there later. But at least in terms of math, 9 to 10 million of Nigerians are living with sickle cell anemia. That's the condition. But the carrier, meaning that people that are AS, was actually assumed to be, in fact, no, documented, not even assumed now, because there are evidence to back that about 25 to 30% of Nigerians have the sickle gene. You understand?
Goodness.
That are carriers.
25 to
So you can
30.
imagine 25 to 30% of 300 million. Now we're talking big numbers. So a quarter of 300 million should give us, that should be like 75. Yeah, 75 million to about 90 million Nigerians being
carriers.
Carriers. Mean that they can give birth, to kids that eventually have sickle cell anemia. You can see that's a worrying.
Yeah, it's worrying.
That's a worrying statistics. So that's where the problem is. There are a lot of carriers. People living with ETS, about 3%, but the carriers, 25 to 30%. It's quite much. That's 1/3 of the population actually AS.
So is this a sickness that affects both blacks and whites?
The condition is been adjudged, not adjudged, scientifically proven that people of African and Caribbean, we say Afro-Caribbean ancestry, are prone to having, the sickle cell gene. Earlier, I said something about the Arabian Peninsula. Yes, they also have a form of sickle cell. Saudi Arabia, Jordan, Kuwait, Iraq, Oman, and all those places as well too. They also have sickle cell because scientifically believe that there was a form of a spontaneous mutation to that occur, in the genetics of those individuals, and also they give birth to offsprings that come down with sickle cell anemia.
So we can conveniently say that this sickness is unique to the black skin.
Unique to the black skin, yes.
Wow.
Or to people of color. Let me just put it that way, to people of color.
Wow.
Because, of course, like during the slave trade as well too, the slave trade actually helped propagate sickle cell anemia. The slaves that were shipped from the western part and the central part of Africa to places like Brazil and to the Caribbeans as well too, you understand? So you can actually have somebody that looks white, you understand, that will still have sickle cell anemia because of the ancestry. If you trace it, you find out that, okay, there was somebody that was of black lineage or African, let me use the word African lineage, in the person's genealogy that must have transferred that gene. Because in Brazil too, they have sickle cell anemia. Mexico, Hispanics, they also have.
So you mean if a sickle cell person or a carrier gets married to, let's say, someone from maybe a white person who is not a carrier,
yes,
they could give birth to an offspring that could become carrier?
Carrier, yes.
Yes.
Exactly.
And then maybe in the future, if that offspring gets somebody who's a carrier, then they could have a sickle cell.
Definitely, exactly, yes. According to Darwin's theory of cross-linking. Yes.
Let's do some linking here.
Okay.
What is AA? What is AS? What is SS? What is BS? All of those things.
Okay. All right. When I was explaining earlier, I said that A is the normal adult hemoglobin.
What does it mean? What does A mean?
A is the normal blood, so to speak.
Okay. Does it have?
That's the phenotype.
Phenotype.
We call it's actually phenotype, not genotype. Genotype is something else. I'll speak about it later.
Okay, phenotype.
So yes, it's just the way that we identify hemoglobins. There are actually many type of hemoglobins: hemoglobin A, hemoglobin S, hemoglobin C, D, E, O, hemoglobin G, hemoglobin Harlem. There are many types of hemoglobins. The commonest ones, so to speak, A, S, C. Yes. Occasionally maybe F because of babies.
ASC.
ASC. Yes, there's hemoglobin C as well. Then there's hemoglobin F. That's the fetal hemoglobin. That's what I was talking about.
ASF.
Yes.
Okay.
ASCF. Usually these are the common ones.
Okay.
So a normal adult usually should have hemoglobin A. A is distinction. So let's just use it like that. So you should have hemoglobin A. And then if you subject it to what we call electrophoresis, hemoglobin is actually a protein, you understand? And if you subject protein to current, they actually migrate, so to speak, until they reach one isoelectric point, you understand? And say, okay, because of the charge, it pushes it to a level. So because of that science, we now do a test that we refer to as hemoglobin electrophoresis. it is also called hemoglobin phenotype. That's the one that people mistake for genotype test. It's actually not genotype. It is hemoglobin phenotype. There's a gene that is expressing that hemoglobin. You understand? So the hemoglobin is a phenotype, is a physical appearance of the gene expressing that hemoglobin. That's why it's called a phenotype. But there's also a genotype as well, to which we'll talk about. So what we commonly do is that it be phenotype, So once you do it, because people have different types of hemoglobins, and you put it under that current, it start migrating, they start moving until they reach a level in which, just imagine magnets. If you have smaller magnets and bigger magnets, it can push themselves apart to a certain length. So depending on the type of hemoglobin, they move at a certain pace. So that's how you're able to identify them on the electrophoretic strip. That's the paper now. So you can see, usually we do it against a control, a labeled or someone that that, okay, this is hemoglobin A, this is hemoglobin S, so that I can identify it properly.
Yeah.
So the normal adult hemoglobin is hemoglobin A. And then if you do a test, we call it a high performance liquid chromatography, that's HPLC. That quantifies the hemoglobins. So that's where you see that, okay, hemoglobin A for normal adult should be about 97 to 98%. A normal adult can have other hemoglobins A2, and you understand, those ones are just roughly maybe 2%, But normal adult hemoglobin A should be 98%.
Yeah.
So on the strip, when they migrate as that hemoglobin A, you just see that one as A band. So that's why they say, because it's one band, they say it's AA. It's just like looking at yourself in a mirror. You understand? A mirror image of yourself should be complete. You should be able to, is it oppose or juxtapose it together, and then there will not be any, space left over. So because it's the same protein, so it only shows as one band. That's hemoglobin A. So when they say HbAA on hemoglobin phenotype, it's actually wrong, because they are not seeing two adult hemoglobins. They're only seeing one. That's hemoglobin A. Because it's a mirror image of itself. Yeah. So it will align on one. So if it's AS, you see two bands now. You now see the A band, and then you now see the S band as well too, because they migrate differently, so to speak. That's what I explained earlier. So that's why when you see those two bands, you look at it against the control, and then you now say, okay, this is hemoglobin AS. So that's the only one that you can rightly say hemoglobin AS. Even for sickle cell anemia, because it's hemoglobin SS.
Yes.
You only see one band as well.
Yes.
So that's I'll tell you where the mistakes come from now in some of those laboratories that are not experienced. So you only see one band because it's S. You are putting S on S. You understand? It's the same thing. So it's not double. You don't see double. You only see one band.
Yeah.
So you can see hemoglobin AA as A on electrophoresis, and you can see hemoglobin SS as S band on electrophoresis. Except if there's a fetal hemoglobin, then you can say SS plus fetal hemoglobin in some people that have fetal hemoglobin. So labs that are quite inexperienced, once they see that one band, some of them will label it as AA, not knowing that the patient is actually, or the person is actually SS.
Oh my God.
That's why it's very dangerous, when you are running laboratory tests. That's what we call quality control. You need to run quality control alongside your test as well too. You use your test, you use it to compare a known standard. Some don't tend to do that, and then they run into trouble and give off wrong report.
Yeah, because I lost my cousin to sickle cell.
Oh, that's sad.
At the age of 5, he was 5.
That's sad.
And what the parents said was previous hospitals said he was AS, or I think, AS.
Okay.
But then the hospital that diagnosed him properly, I think was somewhere here in Jos.
Okay.
They were the ones that discovered that he was
actually SS. Okay.
Yes. So I can relate it, because personally I've done lab tests that I had to go to another lab to confirm, and then this lab says a different thing, the other one says a different thing, Yeah, so these mistakes.
Yes.
How do we stop these mistakes?
Okay, now I'm going to speak from a professional standpoint as a hematologist. Like I said, government they have a role in all these things, My opinion is that the normal hemoglobin electrophoresis, or the hemoglobin phenotype, should not be the gold standard for diagnosis of sickle cell anemia anymore.
Okay.
In Nigeria, if anybody cares to listen to what I'm saying today, we should migrate to using high performance liquid chromatography. That should be the minimum gold standard for diagnosis of hemoglobin phenotypes for everybody. Whether you are hemoglobin A, you are hemoglobin S, SS, AC, whatever, you understand?
Yeah.
High performance liquid chromatography, HPLC for short, that should be the gold standard for diagnosis. Because what that test does is that it does not only identify, it also quantifies the hemoglobin. Now, for example, let me explain another concept. There's also another condition that we refer to as thalassemias. People don't know much about this. I think it was not until, was it 2020 or 2019 or 2021, and I spoke, I think it was on an audio show about thalassemias, and people were like, oh, slow down. We have not finished with sickle cell. You're talking about thalassemias. What the heck? So there's actually another condition we refer to as thalassemias that can also mimic sickle cell anemia.
Wow.
Although it's not too common and we don't look out for it, but it's there, and it has destroyed homes as well too. So hence the reason why I said we should use HPLC as the minimum gold standard. You can do genetic tests, DNA, PCR, and all those things. Usually that's what in US and Western countries, that's what they do for babies, particularly from African descent, of Afro-Caribbean descent. They do their PCR when they get their blood to know whether that one is now genotype, because they are looking for the DNA. They're looking for the codons that code for those hemoglobins. So they see it. Once they see, they know this baby has sickle cell anemia. Even right from day one, they can tell. That one is very, very sensitive. But at least for us here, we can do PCR actually. But for us here, for mass screening and diagnosis, not even screening, you can use the electrophoresis for screening now. Relegate it to screening. But for diagnosis, use the HPLC, minimum gold standard. Now, what the HPLC does is that it identifies, like I said, the hemoglobin, and then it quantifies it. Like I said, a normal adult with hemoglobin A should have 98% hemoglobin A, and probably maybe 2% hemoglobin A2 and all the other sub-hemoglobins. Then, a person living with sickle cell anemia, HBSS, does not have hemoglobin A, so the person will have 90%, 90% of hemoglobin S. Then the other 10% can be other forms, maybe fetal hemoglobin or maybe other forms. Then somebody that is SC as well too. It will tell you that, okay, this person is SC and the hemoglobin S is 50%, the hemoglobin C is 50%. Just like AS as well too. It will tell you this person is AS, so yes, the hemoglobin A in this individual is 60%, hemoglobin S is 40%. Then you truly know that this person has AS. But the danger for people that call themselves AA, I call them dangerous people. Reason being that, I explained something about the mirror image, the A being overlapping itself on that paper. The thing is, if the person has a thalassemia, now let me talk about thalassemia. Sickle cell is a point mutation. It's a disorder in which, let's say you have 50 naira notes, numbered 1 to 100. You understand? And the number 7, you remove that 50 naira note, 50 naira note, and replace it with another note entirely. You understand? Just put it there. It's still 15 naira, but it's another number. So you have 1, 2, 3, 4, 5, 6. Instead of counting 7, 8, 9, 10 to read it like that, it will not be able to identify that 7, and then it continues. That is a problem in the body usually when things like that occur. We call it a mutation. That's a point mutation. You understand? Okay. So because of that, when the body tries to read, as I said, sickle cell gene, it produces the hemoglobin. So when the body is reading it, 1, 2, 3, 4, you should read it 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, I'm supposed to produce this type of protein. But because there's that change in that numbering, it produces another type of protein. You understand? And once it produces another type of protein, it has altered the physiology of that protein itself. So for example, now, medically, on the position, I think is it position 6 now or 7? I'm mixing words together now. So on that position, you have a glutamic acid, so to speak. Is an amino acid. It's being replaced by valine just because of that point mutation. Now, that valine, when it's exposed to insult, for example, dehydration, acidity, infection, and everything, that's when it congeals, it forms that sickle, it forms crystals, and then the cell forms sickles, sickle up. So that's the problem for sickle cell anemia. Now, in thalassemia, is a disease of numbers. The thing is, you should be able to find 1 to 100 normally, like I explained.
Yes.
But you can get there and find only 50. Where's the other 50? Disappeared. It's not found anywhere. So the body will read that 50 and produce a type of hemoglobin as well too. So something has to carry blood now.
Yeah.
Nature abhors vacuum. That's it. That's what we say. So to produce something, but it will not be quality enough to do the job of an adult hemoglobin for a normal human being. So for someone that's AA now, because of that thalassemia, the person only has 50% because the other half is gone.
Yes.
So on electrophoresis, if you do the normal test, you'll see it as HbA. So you think it's AA.
Wow.
You understand? But if you now go and do electrophoresis, HPLC, so to speak, because it quantifies it, and I said earlier, it should be like 98%. Now, when you now see somebody with hemoglobin A 50%, then you know that there's a problem. This person, lo and behold, this person will not have a crisis, will not have any reason to come to the hospital, except maybe something else happens or something, you understand? But related to blood issues like this, will never come. Because the adult hemoglobin, the person's blood level may be lower than normal, but it will still be enough to carry him around. You never know. But the complementary A is absent. So now, such individual that calls himself AA, that has hemoglobin A, 1A, and then the complementary A is absent, marries someone that is AS because he believes he's AA. Now, if you go by that downwind cross-linking, you understand, it will get to a point in time that the absent, the space where the other half of the hemoglobin is supposed to be that is absent, will attach to the S of the partner. And then you have hemoglobin S naught that's absent. That S naught means the one that is absent. So this condition is sickle cell anemia. But the type of inheritance now is not, I said something about homozygous being SS. Same copy, 2 copies now. Now, this person has only inherited 1 copy, and the complementary one is absent, so there's nothing to inherit again. So that's S naught. So this type of inheritance, we call it compound heterozygote inheritance. That's the one that happens with sickle cell with thalassemia. So the person is HBS. Now we now label them HBS beta thalassemia, so to speak. That person will have the same condition, the same sign, the same symptoms, the same severity, the same complication as that of hemoglobin SS. So somebody that have hemoglobin S absent and hemoglobin SS, we have the same thing. So now the fear now is that because I have done the hemoglobin phenotype and I'm AA, my wife is the AS, most likely she must have gone to meet with another man. That's where she got the other S, and that's why the child is SS. Not knowing that he that's AA actually has the thalassemia.
Wow.
That's resulting to the sickle cell anemia for the offspring.
Wow.
It has happened before.
Wow.
It has broken families. It has changed people's lives. You understand? So the things that we see in medical parlance that we don't get to speak out there, we don't get to throw out there.
Question, sir.
Yeah.
This minimum standard you're talking about, is this something that can be done in the villages?
No. Even in the cities, it all depends. If the city have the facility, you understand? It's not something to come on board. I think individuals and then government now, they are trying, to bridge the gap of, diagnostics or diagnosis, so to speak. Let me not limit it to sickle cell anemia. So there's a separate machine that does that, and you might not have it available in the villages, except if there's a way in which you can take samples from the villages and bring it down, to a comprehensive center or to town where those facilities are available, and then the test can be done, and then you can transfer results or the report back to the health centers in the villages. But it's not something that is common. A little bit more expensive, but I think it is cheaper than having a child living with sickle cell anemia in the long run.
Yeah.
You understand? So I believe that HPLC should be minimum gold standard for diagnosis in Nigeria, no longer the electrophoresis strip, so to speak.
Right. Tell me, who should marry who in terms of the crossing, this Darwin's theory?
This question. Yeah. All right. Usually, what we do as pathologists, as doctors, is that our roles are majorly advisory.
Advisory.
It's just to advise, but we don't have the power to say you shouldn't marry this person or you shouldn't marry that person.
Yes.
But ours is to tell you, have the information that, okay, if you do this, this is the thing that can happen, or this is the thing that will happen. So you are making an informed consent, you are making an informed decision that, okay, yes, whatever, come what may, I agree to it, and then you can go ahead. Okay, so now let's look at the genotypes. The phenotypes. Let me use the appropriate word because my scientific community will not forgive me for saying genotype. So let's list hemoglobin. We say AA, at least the common ones.
Yeah,
so we say AA,
yes,
AS,
and AS.
Yes. Then we say SS, AC. Yes, I think that's all, Labi.
Okay.
All right.
We don't have SC.
We have SC. Then we have SS as well too.
So there's SC.
There's SC, yes, SC too. Particularly the southern west part of the country too. You already have
part of Nigeria.
Yes, you already have people that have hemoglobin C as well too. It's a form of a sickle cell as well too, but it's the way it happens is the same thing I explained, but it's just that it's another type of protein that comes in. So it doesn't give the S, it gives the C phenotype, So someone that is also SC also suffers the same symptom like SS. You understand? Although they may not come down with crises as frequently as SS, but they tend to have more of the end organ damage than SS because they don't come to the hospitals for treatment and everything. So the damage goes on and then they have all those complications more. So there's also SC. So that we don't call SC sickle cell anemia. We tend to call it sickle cell disease, so to speak, because the other sickle cell syndrome, anybody that has S in his hemoglobin, you understand, we say the person has a form of a sickle cell syndrome. So AS2 is under the sickle cell syndrome, but the person is a carrier. SS is sickle cell anemia. SC we refer to as sickle cell disease because it's not homozygous S. That is, the copies are not S. One is S, one is C. You understand? So I think we did mention something like that earlier. So there's also SC as well too. All right. So AA is the standard.
Okay.
AA, so they say, let's just go by genetics now. Yeah. So AA can marry any other person. That is, the person is truly AA and not the thalassemic AA. Okay. AA can marry everybody. Can marry AA.
So AA
can marry AA.
Everyone.
Yes. AA can marry everybody. Then every other person will really marry AA. So that's what it means.
Oh, okay. So every other person will only marry AA.
Yes.
Only.
For it to work. AS and AS will not be advisable because there's a 25% chance in each pregnancy. That's what people actually fail to acknowledge. We'll get there. In each pregnancy, there's a 25% risk that the baby will be sickle cell anemia. If you do AS and AS crossing now, you understand? AS, you cross it, AS and AS. Yes. So the first A on the father, when it matches with the first A of the mother, you have AA, right?
Yes.
So these are possibilities. Yeah. So the first A again from the father, if it matches with the S of the mother, you have what?
AS.
Okay. Then the second A of the father,
the A.
The second A now. No, we finish with the first A.
Okay, if it's AA.
Yes, if it's AA.
Yeah.
So the second A now.
Yes.
If it matches with the first A of the mother,
yes,
you have
AA.
Then the second A, if it matches with
this A again.
Yes, if it matches with the S
then we have
of the
AS.
mother. You understand?
Yes.
So AA and AS, these are the outcomes.
Yes.
Possible outcomes in each pregnancy. So that means 50% of chances that AA and AS, when they get married, they will have a child that is AA. right?
Yes.
You have 2 AAs and 2 AS there,
Yes.
right?
Yes.
So that means in each pregnancy, 50 they carry 50% chance to give birth to someone that's AA and to give birth to someone that's AS. That's the that's it. Now, if you cross AS and AS,
Okay, AS and
plus AS. Now, let's do the same crossing. First A to the first A of mother, you have AA. First A to the S of mother, you have AS, right?
Yes.
Then the second S of the father to the first A of the mother, yes, you have AS. And then the S of the father, and then the SS, you have what?
SS.
Good.
So is it possible that AS can give birth to just one sickle cell baby?
It's possible, yes. And it's also possible for them to give up to
all,
10 sickle
sickle
cell. Yes. Because the risk is in each pregnancy. Those days, I think the biology is faithful, or the mistake they made was that, okay, the first outcome will be AA, second one will be AS, third one will be AS. So if you have 3 children, we just stop at that so that we not have the fourth one that is SS, and then we are spared. That was the thinking. And I think that's why a lot of people fell victim to that thing. So it's not like this kind of permutation. It's actually in each pregnancy that the couple have, that you have the risk. You understand? So for AS and AS to marry now, so that means they have 25% chance to give birth to someone that an offspring that is AA.
Yeah.
Then they have 50% chance to give birth to an offspring that is AS. And then they have another 25% chance to give birth to a child that is SS. So the risk is in each pregnancy. I know, as a resident in Jude, I know a couple that all their children, they have 4 children, I think. All of them were SS. All of them were SS.
And the parents were AS?
Most likely. They have to be AS. Or if there's any form of confounders like the thalassemia like I spoke about. All of them. All 4 kids were AS. Were SS. You understand? And I witnessed some complications and some things about the family was broken because of sickle cell anemia. 4 kids. When one of them even got a chance, finished university, served, got a very good job. You understand? The first year, when she got the job, she had a crisis. And unfortunately, she couldn't survive it. It broke the family. They also had the youngest one too that had also died earlier because that one doesn't present earlier. So they didn't know that he was actually SS as well. It was the first time he was coming, which I think they should have even done, but I don't know why. Maybe because he was not sick, so they didn't bother to. First time he was coming to the hospital, telling them that this child is also SS. Didn't survive as well too. I think he was a teenager then, maybe early teens.
So they didn't discover that till he became a teenager?
They did not, because he was never sick. So is that possible as well too? Same disease, variable clinical presentation. Some will not present until 30 years. Some will not present until 50 years. I heard a case. This one is even the person that taught me medical school, a teacher of mine. His father, a farmer all his life, presented at 70 years.
Wow.
Same disease, variable expression.
Yeah.
So severity ranges differs. And that takes us to what we refer to as haplotypes in sickle cell anemia, different types of that variation of the disease. So let's just finish this as well too. So like I was saying, so the chances and the risks are in each pregnancy, not by, the last child is SS, so we will not have that 4th child, we will just do 3, and then we have AA and AS. It's possible that by chance or by grace, AS and AS can marry and they can have 10 kids with AA. It's possible. This is like permutation and combination. They can get married and also have offsprings that are AS and never have a sickle cell anemia. You understand? But the risk is always there. I've seen a couple too that I think it was later they found out that they were both AS and they had 2 kids and they were not sickle cell. So now they know that they don't want to try the 3rd one, because now that they are informed, they don't want to risk it, So they were just, would I say, gracious enough to have, escaped that. But some are not, some were not.
Is it true that there's a medication that a couple that have these phenotype issues
Yes.
can take and then give birth to normal kids?
As a physician, as a pathologist, this condition is inherited. It's largely genetic. So except if the medication can alter genes, I would say no. So the only way you can go about it is genetic engineering. That is, you engineer, what we mean by genetic engineering is that if that couple, AS and AS now, let me just use that word, discordant couple in this regard. If this discordant couple now want to have a child, there are new techniques now that are available. You call it, sometimes there are some of them we call them pre-implantation genetic testing.
Okay.
So they will harvest, their seed. Let me just say the sperm and the ovum, of the woman, and then they will subject them to genetic testing. So the ones that lack that DNA that carries the sickle gene will be weeded out.
Okay.
And then the ones that have the normal gene will be allowed. And then, that's assisted reproductive technique now. That's IVF and all those things. So that's the only way they can do it. So they only pick the ones that lack the S gene and then allow it to form an embryo, and then they will implant back into the mother. So that's the other one. That's the only thing that they can do about that as well too. So there are other tests too that they can do. I'm not so much of into genetic engineering in that aspect, but at least I'm aware, that even before the woman they can harvest the woman's eggs, you understand, and select the ones that lack the S gene, so that anytime they want to have, they can bank them, can bank sperm, bank over. So anytime they want to have kids, if they don't do it physically, they can go to the laboratory, and then they can do it, and then they implant it for her, and then she carries, them to term. So that's the only technique that I know now. That's AS and AS. You can get married, but of course, those kind of things, the way it sounds massive, you know that it's not cheap. If they have the financial powers, then they can do that. Another thing now is this new thing about stem cell transplantation. That's for children that have suffered the condition.
Bone marrow.
Yes. And then this new one too now, we use CRISPR technology now to do, is also a gene modifying measure. US, they say it costs about $2 million now. And in the UK,
for one person?
Yes. And in the UK, 1.8 million pounds, under the NHS to treat somebody with it's largely experimental too, because they are delving into genes now.
I thought maybe the bone marrow transplant has been here for long.
Yeah, in the 80s actually. The bone marrow transplantation for cure for sickle cell actually was discovered by a fluke. The funny thing is that there was a child, an 8-year-old girl that had sickle cell anemia, developed an acute leukemia. Now, they know that stem cell transplantation or bone marrow transplantation has been a known cure for leukemia, in the past. So they decided to treat the leukemia, the acute myeloid leukemia, so to speak, for that child with sickle cell anemia with the stem cell transplantation, with bone marrow transplantation. Unfortunately, the thing wiped the leukemia, wiped the sickle cell anemia. So that's when they now, come, you mean this procedure that we did now actually cured this girl of the sickle cell anemia? So that's why it was discovered. It was actually discovered, I was just by error, just discovered like that, because they were using it to treat something else, and then it cured sickle cell. So that's how it came about. That.
Do we do it in Nigeria?
Yeah, there are people that do stem cell transplantation.
And how much does it cost?
I've forgotten now. Now that things have gone haywire. I know at the point in time it used to be about 10 million. So
10
now
million
I tend to multiply things by 3. So that should be maybe around 13 now in Nigeria. Probably more. Because when you do a stem cell transplantation, the medications that you have to take for 6 months, 1 year, all those things and stuff like that makes it more expensive. So they do. I know people that do it in Nigeria, maybe 1 or 2. I know Sickle Cell Foundation to partnered with one university in Germany or in US now, and they did it for some people too. Was it that last year? So something like that. So
and it works all the time, or it's...
Well, when you do a procedure like that as well too, there are chances. We weigh it in terms of overall survival rate.
Mm.
Yeah,
So
some of them that may develop complications.
what's the idea behind that stem cell? Or is this what is called stem cell?
Stem cell.
What's the idea behind it?
Okay, the idea about stem cell is that you are removing the person's own. The stem cells. Let me just explain what stem cells are so that you get to understand what it is.
Okay.
Stem cells are like they are like the it's like a seed where every other cell of the body grows from.
Yeah.
You understand? That's the stem cell. You know, every other cell that comes from the body, and it depends on where they are. There are stem cells in the liver. There are types of stem cells now. There are some in the liver, kidney, that tend to produce kidney cells, liver cells, blood vessels, blood, and things like that. But now genetically, they can actually engineer a stem cell of blood to produce an organ. That can be done now scientifically. So the stem cell is like the origin of every other cell in the body. It has the capacity to repopulate itself, to divide and maintain itself, and also has capacity to grow into other cells. So now, if they wipe the stem cell of that individual, you know, and replace it with another person's stem cell, you understand? And it's like you're harvesting a seed from maybe US, and you come to put it in Nigerian soil, and it grows, you understand? So you now say, this tree can also grow in Nigeria. So that means you have changed the atmosphere, you know, for that seed entirely. So that's what the stem cell does. You're changing the stem cell of another person, or of that individual to that of another person that is normal. So you expect normal cells to spring up from there and then repopulate the person's stem cell. What they do is that they will kill off the person's stem cell, you know, using high dose chemotherapy. That one is scientific. And then they transplant the stem cell of a healthy person. And if it takes, you know, a lot of things happen actually. Once it grafts, then it produces normal one, and the person is cured of the illness. So that's just the basic layman explanation of what stem cell transplantation actually does, you know, in curing sickle cell anemia. Yeah.
What are some of those most difficult moments, you know, facing people and knowing that you have this condition?
Okay, for example, like I said something about the abiku the other time, you know.
Yeah.
That it's not something. If you know someone that is Yoruba, maybe a person can understand, explain to you in depth what it means to be labeled as an abiku. You know, like you that you will soon die. Maybe tomorrow, you don't know, maybe something you'll die. You know, that kind of mental impact it has on individual. You label like that, you know. Everything you do, you always have at the back of my mind, the person will soon die. I don't know whether I should do this. You can't do that. Why is it that I have to do this? Because he's going to die. Even the parents too, they use that like because he's going to die. Maybe you should not send him to school.
Wow.
Maybe, because he's going to die now. So we can use the fund to, you know, raise other children that are going to live and things like that. So why should we have to spend on him? He's going to die now. Let's just leave him. You know, he dies of things like that. You understand? It's actually something very terrible. And then, as when you're growing up as well too, as children, you know, we tend to say a lot of things to each other. Maybe you get into an argument with a friend, and this one that tells you that you look at you are looking like a skeleton. It's you that want to fight me. Somebody had looked at me and told me that, so you want to fight. Where's the blood that you want to use to fight? You know, those kind of things. And then even at work as well too, like I told you, because he's always getting sick, so we cannot give him this position.
Wow.
I'm qualified for it. In fact, I qualified for it ahead of others. But I was denied the position because I was always getting sick. You understand?
Yeah.
So those are the type of stigma. Or at times when you're at work, because you are overwhelmed, I sit down and they say, there's a patient that I need to go and see something. I need a moment. And they're like, this lazy twat. You understand? So all those things that sometimes they whisper at your back and you get to hear, you know, it builds up. You know, there's a way it affects your psyche. There's a way it affects how you now start reacting, how you start behaving, you know, and things like that. So it's not, it does have its impact, on, that stigmatization. It does. For example, an average sickle cell patient, we have PCV ranging between 17% to, let's say, 30%. 30% are lucky enough, at least 30% they can go around and stuff like that. While an average adult human being should have, let's say, nothing less than 40%. So you can imagine a sickle cell patient, for example, having a blood level of 24, 25%. That's like almost half of what another person have. And you are being subjected to the same stress. Who do you think is going to cope more? Power of life is in the blood. Even the Bible says it. You understand? So if your blood is half of normal, it's as if you have half power to contend with people that have. So you can just imagine. Yes, I'm explaining as if it's mass, but this is reality. I can see it because I have experienced it. I feel it. I know it. Let's run 100 meters now. Probably around 30 meters, I'm panting because I don't have enough blood to carry me. While others, because they have enough blood, they have enough energy, enough oxygen, things like that. You understand? So those are the little things that people don't see in the life of somebody living with sickle cell anemia. That molds the person. Triggers crisis, makes the person think less of himself.
Yeah.
In terms of aspiring for greatness, like, what's the essence? Even if I do this and I become it, should they say the person will die now? Do I need to, let me just relax? Things like that. Limits. So there's no limit to what rather stigmatization can do, in the life of a person living with sickle cell anemia. It's a terrible thing. It's a terrible place to be. There was a particular one that offended me the most. Yeah, and the reason why it's offended me, I've not shared this. I think I told my wife about this. The reason why it offended me the most was that it came from a loved one. It was my father. You understand? I think I was in GS2 and GS3 that time. You understand? She been to be my fault now. Something happened. I got sick. I need help. Take me to the hospital. And I'm sure that was frustration as well too. He just turned around and looked at me and said, "You demon." You hearing that kind of thing from your own father, how do you think you feel? I don't blame him, really. I've forgiven him. You understand? But it's a hurtful word to say to a child. He looked at me and said, "You demon." Why is it that it's every time that I have this, that you always fall sick? You understand? Because you still have to contend with finances.
Yeah.
Hospital bills are not really cheap and things like that. So the social aspect, these are the things that have molded me to the person I am today as well too. Today my father is late, but he's still the greatest man alive left for me. I mean, that had lived left for me. I'll never hold it against him, because the same person that said that was the same person that nurtured me to life when I was sick. You understand? So there's no way I can count it against him. But it's something that can come from anywhere. Even your own personal person can look at you out of frustration. That what is it now? Is it only you? Within 1 month, you have been sick like 6 times. Money that we have used to buy land, to buy car, to send somebody else to something, to sponsor another person, you put it in your medical bills just for you alone. What is it now? You just could go and die. Not that kind of thing. You understand? I'm not saying he said that. I'm just saying now.
Yeah.
That might be another person's reality.
Yeah.
So why should we have to waste so much funds on him? Because he's going to. So why? So just picture that. So it's a whole lot. For somebody living with sickle cell anemia, dealing with his own, condition. Then I have to come outside again and deal with people again. You understand?
Yeah.
So it's actually a whole lot.
So, yeah, this is very painful and difficult. I can imagine.
Very, very.
There was a woman who lost 9 children.
9.
Yeah. how can a person living with sickle cell manage their pain?
Okay. The thing is, a person living with sickle cell can, from what I've experienced, you always need help. You can't, let me just say, stay on your own. Because of those days that you require help, when you cannot walk because of pain, when you cannot even brush your teeth, you will need people to take care of you, to take you to the hospital. It's things like that. And of course, when you're in the hospital, if you work in a private firm, of course, they're not going to pay you because you didn't work. As a result of that, I even had a friend that lost her job because she was sick. The boss just said she has had enough of it and just sacked her because she has sickle cell anemia. You understand? Stigma. So they always need our help. They always need to be monitored. Pain is not something you manage on your own. The pain, mostly physical, but eventually over time, it becomes psychological.
Yeah.
Because it starts affecting your body, your mind, your pocket. Even with sickle cell anemia, fired, you don't have a job. You don't have a job means you don't probably have a means of income. You don't have an income, so how do you take care of your medical bills? So you might need people to help you, in that regard, if you have good friends, good family members and stuff like that.
Yeah.
But if you're not looking at the physical aspect of the pain, yes, like I said, pain is subjective. Some may be able to use their mind or the will to overcome the pain and say, okay, no, maybe I shouldn't go to the hospital. Let me just stay. Some take pain relievers, maybe like tablets that you can buy on the counter, paracetamol, ibuprofen, diclofenac, and things like that. When it doesn't work, some go to the hospital and then they get admitted and then you get hit with the heavier drugs that you cannot just buy, the controlled medications now, which is subject to abuse because of, of that. So it's not something that they manage on their own. And because of that now, even some of us as health workers, when they see someone with sickle cell anemia coming in pain, they stigmatize the person that, this opioid junkie has come again.
Wow.
Whether the pain is right, whether the person is not in pain or is just wants to get pain medication and then they faint. You understand? But you label the person as an opioid junkie. You understand? Even as health workers. So there are so many factors, that affect. And for me, because I understand it, because it's been my reality, I know what it means if somebody living with sickle cell comes in pain and then somebody is now withholding a type of medication from the person just because he said, I don't want the person to get addicted. You don't want the person to get addicted, but the person is in written pains. So what are you doing? You leave the pain now. What's your problem? You get addicted. There's no way you can eventually. What I've experienced. Maybe it doesn't be documented. After a while, yes, some will request for it. And I think them requesting for it should not be subjected to abuse. Even if they're abusing it. But some had the right reason to request for it. Because that pain is not something that you can just imagine. They need help. Help them. Then you can assess gradually. Although I know some can lie just because they want more. That, okay, you should be out of pain now and then you should wean it off. Just cut it off. I think that's the problem as well. They cut it off just immediately like that and they have to wean them off. Reduce the dose until you change it to something else. Or you substitute it with something else and then you stop. You wean it off. That's what I found out. A lot of people don't do that. And that's what I do for my patients. I wean them off those medications. While I replace them with another. And then the pain management is better. And then they get discharged. Some stay longer. that one, then when I know that, okay, some stay longer genuinely, or when some stay longer as a result of, I knew that, no, this person, you're already feeling this thing. I think you can go home. You can manage this thing on your own. Sometimes I talk to them, I counsel them. That the same way you know this thing, I know it as well too. I think by this level, at this time, what we have done so far, should have managed your pain. Snap of it. And sometimes when you talk to some of them like that, they actually, comport themselves and then they go. So I've seen them as well too, in that regard. So when they ask for it, don't label them as opioid junkies and stuff like that.
Okay. Dr. Shagun, walk me through, why are you a doctor? At what point did you decide that you were going to be a doctor?
I had a very loving mother, as in she's very, very calculative. She has been singing it into my consciousness as early as I can remember. Even when I'm taking my bath and she's bathing me, she was like, so you're going to be a medical doctor in the future, that kind of thing. Wow. When you start singing it or saying it into the consciousness of a child. Yes, that was my mom. So she always encouraged me, test, exams, anything that, you must read very well because you're going to be a doctor, so you must know everything. My father also knew about that whole concept that your mother has been telling you that you are going to be a medical doctor. So okay, no problem. One day I just came home. My dad had already bought jam form. Had already filled the jam form. It was just for me to come and append my signature. Lo and behold, he had fixed it. He has put the course there, medicine and surgery. I was like, Daddy, I was going to do computer science and engineering. He said, no, that is medicine and surgery. He has already written it there. So it's not going back. So it was cast in stone. There was no way I could change it. So I fixed my signature and then it went, and that was it. I wrote my GCE 1998 in SS2. And when I was writing that GCE, I had a crisis. I was literally in pains from day 2 till the end of GCE exams. Wow. And I refused to go to the hospital. I was writing my GCE in crisis.
How did you choose pathology? Is it something related to your experience?
Yes, it is largely. Although medical school, I excelled in various aspects of medicine and surgery. I wanted to even be a neurosurgeon. But that took a turn when I was an intern. I was assisting one of my senior colleagues during a surgery and I collapsed. So that day and I thought that, okay, what if I was the main surgeon and this happened to me? What would have become the fate of the patient? So I said, I don't think surgery will be the better thing for me to do at this point in time. So let me strip that off. So I wanted something in which I'll be comfortable in my sphere and also be able to make an impact.
Yeah.
So I looked at myself as well and I come. I've been living with this condition and I know hematology is actually usually the forefront managing this kind of condition. So it kind of channeled my orientation. Even if I had chosen pathology, I would have done morbid anatomy, histopathology, forensic medicine and stuff. But I said, no, hematology is just it because I think I should be able to relate more with hematology because of my condition and also be able to help my patients better if I have knowledge, awareness, if I have medical knowledge, core medical knowledge about how to treat, to develop new agents or medications for treatment or alternative means of managing the condition as well too. So that's basically what spurred me, into being a pathologist and then so specialized in hematology and transfusion medicine.
Wow. Yeah, that's amazing. Yeah. Tell me about your wife. How did you meet your wife? What's your love story? How did she say yes?
My wife is an amazing woman. She's really, really amazing. And I think I can consider myself as the luckiest man on earth, because, with people having more knowledge about sickle cell anemia, so why would you, in your crazy mind, want to leave or go ahead to marry me when you know that these kind of things are going to, come up and become, a problem? Well, I had issues as well too with dating, you understand, because of obviously sickle cell anemia. The ladies I met as well too, they have to be AA. It's not Whether because I love you, love conquers all. Love does not conquer all. Anyways, let me just put it that way. It does not, So I had a heartbreak as well too. The person I was really, I would say my wife eventually was the one that pulled me out of that heartbreak. But the person I was really, really into that time when I was in medical school, she's a doctor as well too. She thought, because I told her, I am this, you understand? The only way we can work together is you are AA. And she said she's AA. I was like, okay, no problem. So right from the beginning, I had already spelled it out. I was a medical student, so we knew the impact of what could happen. Unfortunately, one day she wanted to donate blood for I think an accident victim, and our boss or our teacher collected her sample and tested her blood and found that she was AS. And that fractured the relationship. I even had an accident when trying to come down because that time I was doing my house job in Kano. I was coming down to Lorraine to meet her so that we can discuss things. I had an accident on the way. I almost lost my arm. It was a ghastly one because the man died in the fallout of the accident. So I was still lucky again, so to speak. I was gracious enough to survive it. So it fractured the relationship, and because of that, I stayed away from dating for a long time. So I actually met my wife when we were in service, youth service. I was posted to Abakaliki in 2008. I applied for relocation because of sickle cell, but because I was a doctor again, I was deprived. They kept my application somewhere. They didn't allow me go. They thought I was lying or things like that. So I've had my I had my own share of, so to speak, let's say maybe bad deals, so to speak. So I was not able to relocate, so I stayed back. Then when I had crisis, of course, the state coordinator took it upon herself, gave me a pass, went home. She said, anytime I feel like coming back, that every other thing that was to continue, they'll continue paying me and things like that and all. So the way how I met my wife was that I was in my room talking to another flatmate, actually. And she missed her way, actually. She was supposed to enter a room before mine. And she just opened the door and entered my room. And immediately I turned like this and I looked at her. Something within me just said, this is your wife. I don't know how to explain it. I just looked at this woman. And something said, this is your wife. That was the conviction I had. Nothing else again. And I wasn't looking anywhere else again. Just said, this is your wife. And I was like, okay, let's see. Let's see what turns out of it. And we got talking, talk. Of course, first things first, I need to ask, are you be AA? Yeah, I'll be AA. Don't tell me whether is something else. No, that she's AA. And it got off from that, from 2008. We got to know each other for a while because I was a set ahead of her. So I had to leave, I think, about 6 months after she continued. And we were friends till 2012 when we got married.
Is she a doctor as well?
No, she's not. She's a journalist.
Okay.
But she's a baker today now. She bakes.
How did she accept you as a sickle cell
person? I'm sure there's a lot of story behind that she did not tell me. Maybe because she didn't want me to feel bad. Because I was sure her parents must have told her otherwise. That, are you sure? The thing about sickle cell, like I said, I come from the West. I'm from Kogi, but Yoruba part of Kogi anyways. Yeah. So I still regard myself as West. The Abiku thing. Like, are you sure this one? To some extent, I felt probably with my past relationships too. Maybe somebody too could have lied that, okay, she's no longer AA, she's AS. And felt, because I had sickle cell, so she was not seeing a future with me. That probably maybe at a point in time, this guy might just die off. I didn't hold it against her anyways. But, so that also came to bear. Like, I asked her like 3 times, are you sure? Because there was a time I was sick in the hospital, I was hospitalized, and she had to come. And she saw the whole thing. I wasn't easy about it. And I told her that these are the things that you'll be seeing. Are you sure you can cope with this? And each time I asked her, she would be like, am I not the one making the decision? So why are you asking me again? I've told you what I've told you before. You understand that it doesn't really matter and things like that. That's why I said, I think I'm just the luckiest guy, for me to have, scored, so to speak, in that manner. So she's a strong woman. She's always there for me anytime I'm down. Even if I'm not down and things like that, she's always been that supporting rock also, for me and stuff like that. So yeah, I'll call her a superwoman.
So with your children now, are you affirming that children with AS can
Yes.
easily come down with malaria?
Yes, well, medically speaking, and if you go by physiology,
Yeah.
you shouldn't actually frequently come down with malaria.
Yeah.
But I think one of my daughters do anyways. But the funny thing is that they don't listen. Children, close the door. Those they will not do. They get bitten by mosquito in the morning. They come and show me, Daddy, mosquito bite, mosquito. I said, I told you now. Don't open the door. Close it. So, but I believe they fall less ill to malaria because of what medicine has actually explained with that red cell being sickled if it has a sickled hemoglobin, and because of the change in the nature of that hemoglobin, the body can destroy it and will prevent the malaria from spreading to other cells. So they can also have it anyways, but the risk might be less than people than AA. But in people that have SS, it actually triggers crisis for them because the body will destroy more of the sickle cell, and then they'll have a crisis, especially a hemolytic crisis. They can also have abuse as a result of that as well too. So that's it.
Wow. Really. So in closing, I want you to speak to that one person
Okay.
that is losing hope,
Okay.
that has no hope again because of their condition.
Okay.
Sickle cell.
All right. Living with sickle cell it's a challenge. No wonder why they call people living with sickle cell warriors, because the fight is an everyday fight. And you have to come out tops every day to be alive. So what I have to say is that if I'm being benevolent enough to be here speaking on this podcast, I've had near misses as well too. You understand? Just do not lose hope. Another secret is that just be joyful. Don't let anything rob your joy. That's one thing I've learned. Just be joyful. Be happy. The Bible says that a broken spirit dries the bone. So don't let anything break your spirit, not even sickle cell. Believe in God. Do what you need to do. Drink lots of water, eat well, rest well. Know your triggers. Know your limits. Do not be dismayed. And do not let anybody talk down on you because you have sickle cell or not. Because it's not of your own choosing. You understand? The more reason why you should show more resilience, that yes, you can fight this thing, you can beat it, because you have something to show and you have a story to tell. That you are who you are, not defined by sickle cell anemia, but you are who you are because of the way God has created you to be. So hang in there, don't lose hope. Remain focused, remain strong. And I believe all will be well at the end of the day.
Dr. Shegun, thank you so much for your time.
Thank you for having me once more.
Thank you for taking the time to share your personal story and your experience.
It's a pleasure.
I wish you all the best.
Thank you.
I'm sure that what we've discussed here will go a very long way in enlightening people about sickle cell and giving hope.
Yes. That's the essence. Of the discussions, and also to give, just like you said, hope, even to parents that have children with sickle cell anemia. So don't say because they have sickle cell anemia will not sponsor them. They can aspire to be everything great that there is to be. So you just have to be supportive and nurture them to their aspirations as well.
Thank you for watching The Yellow Mic. My name is Kongs Shamaki. I'd like to invite you to help us reach 1,000 subscribers. Also, like this video and share to your friends, and let me know what you think in the comment section.